the last talk for the session is by Dr. Sudha. She's going to talk on another case of IIH. After that, we'll have discussion on all the topics so far.
Thank you to the organizers for giving me an opportunity to present today. I will be sharing with you a patient with idiopathic intracranial hypertension. I have no conflicts of interest to declare. I would like to acknowledge Professor Chen and Dr. Pratyush Giri, who were both also involved in the management of this patient. So a 54-year-old Caucasian lady presented with symptoms of gradual onset of blurred vision, progressing to tunnel vision. She also had symptoms of persistent headaches and diplopia. She had symptoms of pulsatile tinnitus and transient obscuration of vision. She reported that she had lost 20 kilograms of intentional weight loss, which she had achieved through diet and exercise prior to the onset of these symptoms. Her past medical history was unremarkable. She was on Duramine for weight loss, and she denied history of intake of any medications, including tetracyclines, oral corticosteroids, lithium, or vitamin A. Sorry, I think it is going, my slides are progressing without the mouse click. Sorry. I think it's just progressing. Okay, I'll just continue. Okay. What's that? Yeah, okay. So on a presentation, she was noted to be obese. Anterior segment examination and cranial nerve examinations were within normal limits. The neurological examination was normal. Fundus examination was suggestive of papilledema with evidence of grade 2 frisson grading in right eye and grade 1 in the left eye. OCT nerve fiber layer demonstrates optic disc swelling, which is worse in the right eye compared to the left eye. She underwent a Humphrey visual field, and as you can see, there was no evidence of enlarged blind spot or peripheral field constriction. Possibly there's some nasal step on the left eye. She had MRI of her brain, which did not show any space-occupying lesion or demyelinating lesions. However, there was distension of the perioptic subarachnoid space, posterior flattening of the globe. She had partial empty cellar and also CSF distension of the Meckel's cave. She underwent CT venogram, which did not show any dural venous sinus thrombosis. She underwent lumbar puncture, and this demonstrated an opening pressure of 40 centimeters of water, and the CSF analysis was within normal limits. So she was diagnosed as idiopathic intracranial hypertension based on the fact that she had papilledema, normal neurological examination, MRI findings with no space-occupying lesion, and CTV showing no dural venous sinus thrombosis, normal CSF examination, and an opening pressure of 40 centimeters of water. So she was started on acetazolamide, 250 milligram 3 times a day, which was progressively increased, and she was advised weight loss. 3 months later, she presented to our unit, and at this time, she still had persistent headache. There was no evidence of tinnitus or transient obscuration of vision, and there was the disc swelling itself was settling down. So here's the OCT. You can see that the disc swelling is settling down, and comparatively, this is the baseline OCT. So while these features are typical of idiopathic intracranial hypertension, there are a few atypical features in this presentation. So first of all, the age. The patient is not in the normal demographic of the patients presenting with idiopathic intracranial hypertension. As we know that the patients who it can happen in patients with older age, but they tend to less likely have symptoms of headache, and they're usually not obese. And secondly, as the patient reported, she had preceding weight loss at presentation. I think my thing is just going on. Okay. So she had the hematological, so we ruled out basically the secondary causes of idiopathic intracranial hypertension, and there was no evidence of anemia or polycythemia. CTV was already performed. She denied history of systemic diseases, including chronic airway disease or obstructive sleep apnea. Renal functions, thyroid functions, and parathyroid levels were all within normal limits. We re-evaluated the medications, and there was no suggestion of secondary idiopathic intracranial hypertension with the medications. So the same treatment was continued. She was advised weight loss, oral acetazolamide was continued. 6 months after the initial presentation, she presented with severe headache, tinnitus, recurrence of papilledema of grade 2 to 3, and she had bilateral six-nerve palsy, paresis. And she had self-seized her Diamox due to the typical side effects that most patients have. Any suggestion from all of you as to what I should do now? I think my slide gave away. Okay, I'll continue. So we went on to take further history from the patient, and she described having cutaneous lesions in her lower legs and the right hand. Now, these lesions that she had were annular scaly lesions. So biopsy was performed from these lesions, and they showed evidence of atypical lymphocytic infiltration of the dermis and the epidermis. While I do not have picture from the patient, but this is a typical presentation of patients who present with mycosis fungoides. So this is what, this is a much later case. Our patient, it was not so significant. She had just annular scaly lesions. So at this time, she was reviewed by the hematologist. Peripheral blood smear was performed, and this showed evidence of leukocytosis with lymphocytosis. So she underwent flow cytometry, and the immunophenotyping was suggestive that the B lymphocytes were normal, and there was no evidence of B cell monoclonality. She basically had T cell lymphocytosis, and these were suggestive of, there was an increased population of CD3 and CD4 cells, but the CD8 was within normal limits. And the CD3 and CD4 cells were positive for VB16 marker, and this clinched the diagnosis of cutaneous T cell lymphoma. So she had repeat lumbar punctures over the next 6 months, opening pressures 27 and 25 centimeters of water. Biochemistry showed mature lymphocytes, probably in the higher limits of normal, but still within the normal limits. Protein and glucose was normal, and unfortunately, she did not have CSF samples which were sufficient for flow cytometry. She underwent PET scanning, and there was no focally avid lesions involving the lymph nodes or the bone marrow or any other organs, but she has some cutaneous lesions as is seen in the right hand and also in her legs. So further investigations showed that she had persisting leukocytosis and abnormal lymphocytes. CT, chest, neck, abdomen, and pelvis showed no pathological lymphadenopathy or no other organ involvement. She underwent repeat MRI of the head and spine, and there were no intracranial lesions or evidence of CNS lymphoma. So here we have a 54-year-old patient who is obese, raised intracranial hypertension, normal CSF examination, and radiological features suggestive of idiopathic intracranial hypertension, but she also has an associated diagnosis of cutaneous T cell lymphoma with no CNS involvement. So cutaneous T cell lymphoma is a rare hematological malignancy that typically presents with cutaneous lesions. The CTCL can have a wide range of outcomes, from indolent and favorable outcome as seen in mycosis fungoides, or rarely it can be a more aggressive and morbid outcome as can be seen in Sézary syndrome. Visceral metastasis is uncommon, but it can occur, and CNS involvement is typically rare. What is usually seen is that these patients actually have large cell changes, and then they can go on to have visceral metastasis before CNS involvement occurs. Now, CNS metastasis in CTCL has poor prognosis, and the patients require treatment with radiation, surgery, and high-dose methotrexate. So the probable diagnosis in this patient is paraneoplastic syndrome associated with cutaneous T cell lymphoma. The possible etiology here is increased white cell count, which has resulted in increased resistance to the flow of CSF from arachnoid villi into the sinuses, resulting in increased intracranial pressure or papilledema. CNS lymphoma is unlikely because imaging studies were normal and neuroimaging was also normal, and CSF fluid did not show any abnormal lymphocytes, and papilledema resolved after the initial lumbar puncture. Now, paraneoplastic syndromes are immune-mediated response, and they can present with paraneoplastic antibodies or CSF lymphocytic pleocytosis, high IgG index, and oligoclonal bands. Pseudotumor cerebri or secondary idiopathic intracranial hypertension has been reported in patients with chronic myeloid leukemia, acute myeloid leukemia, and acute lymphocytic leukemia, and also acute promyelocytic leukemia. And the pathogenesis is somewhat similar to what I have just described with the increased white cell count, or it could be from CNS infiltration. However, in leukemia, there's also a risk of disseminated intravascular coagulation, which can result in dural venous sinus thrombosis. Now, the patient was subsequently managed with Diamox, topiramate, and she also underwent a VP shunt to relieve her symptoms of headache. With regard to the cutaneous T-cell lymphoma, she was managed by her treating hematologist. So the lessons that I learned from this patient is that it's important to examine the patient as a whole rather than just do an eye examination as an ophthalmologist. It's always important to consider secondary causes of idiopathic intracranial hypertension in patients presenting with atypical presentation, including older age, males, or normal BMI, also patients who may present with cranial nerve other than sixth nerve palsy, or they may have additional neurological features. Fortunately, this patient had a good outcome. However, CNS lymphoma has a poor prognosis, and early diagnosis is critical. So I'll leave it for you all to decide whether secondary idiopathic intracranial hypertension or pseudotumor cerebri is a better term, because here we have an etiology, but the pathogenesis is not known. Thank you, and sorry the slides kept going on.
Thank you so